Okay, good morning, everyone. My name is Andrew Blustein. I'm the chairman of Garfunkel Wild. I am very excited to welcome Dr. Vincent Grasso, who agreed to speak to us on the role of artificial intelligence in enhancing healthcare delivery. Dr. Grasso is a research professor at the Department of Electrical and Computing Engineering in the University of New Mexico. And on looking at his bio, we have a problem because this is a 45-minute session that would, if I read the entire bio, it would be an hour. So I'll just give you some of the highlights. Why I think Dr. Grasso is excellent to speak to this symposium is he's both an expert at artificial intelligence and also a practicing physician. So that is an incredible combination for our audience. Just to run through his education briefly, he has an MBA in business process engineering, re-engineering and finance from the University of Massachusetts. He has a master's of science in information systems from the New Jersey Institute of Technology. He is medical information research, was a medical informatics research fellow at NASA, program manager at Yale. He did a minimally invasive surgery fellowship also at Yale and a general residency fellowship at Mount Sinai, internal medicine internship at Robert Wood. He's a doctor in osteopathic medicine. And he has degrees that my mother would be proud of. But where I think Dr. Grasso really shines, I think there's three parts of his repertoire that I want to focus on that I think will come out during this presentation. So first of all, he's what I would say all things AI. He was the healthcare and life science global practice leader for Amelia Inc., which is the world's leading private AI company. So that's the entrepreneur part. There's his consulting practice where he helps providers figure out what they need in terms of AI and to evaluate. And that's reflected in his, he completed a successful technology stack migration to use AI for rapidly expanding federally qualified health center in Chicago. And three, he's also a provider and was a physician with a multi-specialty clinic in New York. So you see the entrepreneur, you see the consulting, and you see the provider. And if that wasn't enough, I don't know, Vincent, when you sleep, because he's also the director of social media and strategy for artificial intelligence surgery, which is the only peer review surgical journal dedicated to all things AI. Like I said, we could go on for hours about your background, but that would be boring to the audience. That it would
Sure.
not get us where we need to go. So, Dr. Grasso, thank you so much for joining.
Thank you.
So let's start out with a question. I'm blessed by knowing nothing. So let's start out with very basic. What is the words artificial intelligence? Is it just a computer that's faster than the prior computers, or is it something more?
You know, it's a seemingly simple question, but under those two words, you know what I do when people ask me what's AI? I ask them to tell me what intelligence is. And say 40 years ago, 50 years ago, before computers or anything else, if you ask someone, can you define intelligence? They probably would, be able to walk through it and describe, the ability of the human mind to solve problems. And the more complex the problem, quote, the more intelligent the person, right? So I take it from that perspective of let's define intelligence first. There's lots of definitions about intelligence. I like the one that talks about the ability of being creative, practical, and analytical. And the people that we think about in the past that we would consider the most brilliant, right, have always been those type of Renaissance people that were creative, resourceful, and building and analytical, right? Those very gifted people that could paint, sculpt, build things, and solve complex problems. They're always the people we admire. So if we agree that intelligence is a function of complex problem solving, before there were computers, people could do that. The artificial thing simply is the ability of doing that in the absence of, flesh, the absence of a brain, the absence of humans, which is synthetic. So if you could cobble together hardware, software, applications, algorithms, all that stuff, and solve complex problems in a creative, productive, and analytical process, that's really what artificial intelligence is, right? So it's something that we really understand. It gets confusing in the, let's attempt to define it, but it's what most people do they know what intelligence is, and
Right.
then achieving that with the use of synthetic silicon is the artificial piece to it,
Right.
and that's why it's an interesting topic.
So I'm going to keep asking you absurdly easy questions, which are almost impossible to answer, right? So, okay, I get that in an abstract level, but it seems, and I'd be curious why this is, I have no idea. It seems in the last 12, 24 months, the word artificial intelligence, you can't pick up a newspaper or read an article without it coming out. It's in everything, right?
Yeah.
But we've had computers, I don't know, 20, 25 years. Why, again, going back, why is that phenomenon happening, and why aren't we just calling it computers?
So the since the dawn of the processor, right, the microprocessor, and its ability to crunch numbers, it's been around for a while. They got better and faster and less expensive over time. So did all the other hardware and software and network that came along with it, right? It's all gotten really good and better. The difference between the traditional use of computers and software and hardware has never really been to allow it to think and be creative and to assess information and provide insights, right? We've used them for basically crunching numbers, right? We've used them to do word processing, statistics, but they're essentially been used to even when you're processing video, there's the math behind it that you're doing, right? It's not intelligent. It's executing on what it's designed to do. And it's only in the past 10 years, really, right? 5 years that now, especially in the past 2 years, that, like you said, you can't get around the corner without somebody bringing up the topic of AI.
So I'm going to pick up on the word. We're going to come back to it because when we talk about risks in healthcare, I think we're going to need to ponder that. So the difference between artificial intelligence and your regular word processor is we now have creative problem solving, which means learning, I take it, right? That the
Yeah,
AI can learn.
yeah. So remember, the machine doesn't know anything until you train it. So there are a couple things that you have to be able to do. Number one, you have to be able to create programs that allow you to train machines, right? So that's that has to come first. How do I train a machine to learn is in fact a program. And then what information, what data do I give the machine to allow it to learn and train? And and part of, I think, the way that I learned these complex topics was I try to bring them back, and I had good mentors bring them back to very simplistic things. When you have a child, a little child, 1 year, 2-year-old kid, when you teach a child something, do you try to trick it? Do you teach it about fire by letting them get burned and say, don't do that again? No, you take a lot of time and effort to train children and learning, and you don't trick them, right? The color red is the color red, and you say this is the color red. You don't say this is blue and then it's red and it's yellow tomorrow. You don't trick the child. So part of training machines is giving it good data, and that's where there's an interesting blending of what's good, best, the ultimate data set that you train a machine in, and that's part of the whole learning environment for machines, and that's a big open area right now.
So having just become a grandfather for the first time and watching my grandson start to learn things, um, is there then, well, I'll put it this way. Well, I was going to ask you, is there really a difference then between machine learning, so they start off at one point and they get better and better.
Sure.
Uh, I don't think my grandson's going to keep being amazed by the mobile above his crib, but eventually he'll get to other things. If that's the same thing as artificial intelligence, then I would say, is as we bridge into this conversation in healthcare, are there things that AI can't do in terms of just, we're being very abstract and we're going to get more specific,
Sure.
but are there limits once you get the program trained and it's learning? Are there limits to that?
Well, I mean, limitation is a function of scaling. So, for example, your grandchild has a brain with a fixed amount of neurons and ability to process. He may or she may possess some gifts, some abilities to do things because simply, the child has the brain to allow them to do things like we know kids that they're 3 years old, they can paint, they can play the piano at 5 years old. That's you didn't they don't learn how to do that. They have an architecture that allowed them to do that. That's called being gifted. But they have a limitation to how fast they can learn and at what scale. Now, that what's nice about AI is that there are ways to learn that by throwing resources at something, you can in fact learn faster. And humans can't do that. We can't make our minds 10 times larger than they are to learn 10 times faster. So the machine has the advantage of having more resources available to it to in fact learn faster, learn things in parallel that humans can't. Humans can't learn in parallel, right? You can't learn 9 languages at the same time. Just like talking to me right now, you can't in your mind sing a song and tap with your hand another song all at the same time. We can't do that. And machines can. So there's where there's an advantage and a very big difference between machine learning and how we learn. But the architecture and the foundation is similar, right? The construct of what learning actually is.
So it's fascinating. We're going to stay abstract a little bit more, and then we're going to get practical because we
Sure.
first need to understand we need to understand the abstract. So when we talk about applying AI in healthcare, so the first thing that occurs to me as a patient is, what if the AI makes a mistake, right? What is
Yeah.
that going to mean to me? And I do read articles, about this concept of drift and making mistakes. Can you speak to both of those?
Sure. Well, I think first, you remember in the old days, we referred to patients as patients, right? But they're actually customers, right? I mean, now they're referred to as customers because they in fact shop and they select things. And patients are aware that mistakes can be made, and there's no power in the universe that's going to stop a mistake from happening in healthcare because they happen every day. Now, there's mistakes that are of very little consequence, and then there are grand mistakes that are of profound consequence. So, for example, a mistake that the AI could make perhaps is in scheduling a time wrong for you to see a patient, that there was a blip in which table your appointment went in. Instead of tomorrow at 10 o'clock, it went in Friday at 10 o'clock. That's a
Mhm.
mistake, right? There was a scheduling error. What's the consequence of the scheduling area? There's not a real healthcare risk, but there's a logistical and there's other problems that arise from that. So those are the kind of risks that humans make, machines could make. What we don't want to have happen is the machine making a series of mistakes that take you down a very dangerous path where your blood sugar may be too low or too high, and it's guiding you along a trajectory of a treatment plan that's not correct for you, and you wind up having very low blood sugar. You get in your car, drive, and now you've had an accident. Those are the kinds of things that you don't want to happen, and they have to be absolutely prevented. But when the training data sets get corrupted and or, as you mentioned, drift occurs, the machine isn't doing it on purpose, right? Unless some agent entered its environment. But the data that it's looking at could have been changed, and the algorithm changes and it starts to move in a different direction that's not checked. And that's the danger of, quote, drift. So there's a lot of areas that you have to mitigate against to not have the machine make mistakes, short term, midterm, and long term, and that's called surveillance, right?
Right.
You need to be aware of what's systems where AI is just another one that's a little more complex, obviously, but that's
Right.
the space we're in.
I guess it's no different than, either a doctor who's suddenly having malpractice and goes for some retraining, right?
Yeah,
Or a car that's got that rattle and you take it in and they fix it. Things have to be maintained and surveilled. It's not like it just doesn't change, right?
yeah, in a fluid environment, um, fluid environments are different than static environments. For example, if a machine part, there's a machine part, there's a piston in your car, and it goes up and down millions and millions and millions of times. Eventually, it wears out. You have to change something. That's predictable failures. That's very well modeled. When you have AI playing in a lot of complexity, looking at different databases, making different decisions based on complex rules, well, then the chance of having a mistake is much harder to predict, requiring, therefore, a greater level of regulatory surveillance knowledge by the stewards of the platform, right? That's where it becomes complicated. And that's why, I'm a big proponent on, doing a lot of thinking and figuring out before you go and indulge and buy, right? Because that's the challenge, right? Is, you know, how do I surveil? How do I monitor? How do I police in a healthy manner, but use the benefits of the product, accepting some risk? That's the dance, right? That's the
Right.
dance that we all live in.
And we're going to touch on that theme as we go through. But you've been doing. I know you did some telemedicine from Mount Everest in I think 1988, right? So you've been involved in technology and healthcare for a long period of time. Um, I guess my question before we move in, can you help the audience understand why now, when everyone thinks, I mean, not everyone, when many people think about artificial intelligence, they're talking about things like chat GPT because they can get it,
Sure.
for free, and they can do, write my son's paper in 5 seconds. That's different than the products that you're evaluating for clients and that you're seeing being used. Is that right, or am I wrong about that?
Well, there's let's just talk about what I call the AI ecosystem, right? Because the AI ecosystem is a combination of lots of different products and tools and techniques. For example, you brought up chatbots and avatars, right? That lives in the classification called conversational computing, right? You're able to engage with an avatar, a chatbot. Maybe it looks like you, maybe it looks like me, maybe it looks like whoever we want it to look like, right? So there's customization that's afforded in that environment. And you ask questions and it gives you answers, or vice versa, right? That's the conversational piece. The other part we're talking about is the machine learning piece, right? All of the stuff that's happening behind the scenes, crunching through big data sets and extracting information that wasn't obvious or what have you. That's the machine learning heavy computing stuff. And then the third leg of the stool is what's called robotic process automation, the execution of these processes through non-human labor. And that three-legged stool creates a whole ecosystem that an organization can take advantage of. Now, generative AI, and all those things like you mentioned, having an essay written by the machine based on a topic that it learned, yeah, that's a module that lives within that architecture. And what you don't want to do is start picking and choosing from the shelf these pieces and not understanding how to leverage and control them, and just throwing them into your stew, so to speak, without having the whole technology stack that you have really evaluated properly. And that's where I think a lot of the risk comes in. If you want to go fast, you want to be current, you want to be cutting edge, you want the marketing people to be happy. We're doing AI, and you got to be careful when you go down that path that quickly.
Yeah, for sure. Um, like we're starting to see that with some, the cars that drive themselves. Everyone was a rage, and now they're wondering, right? There's some bad products. So let's start to apply the abstract to the specific. And I want
Sure.
to start with clinical operations.
Okay.
I read about a study that really fascinated me. I think it came out of the UK, where they took two radiologists that had been reading mammograms for decades, and they compared them against a radiology program that read mammograms that was artificial intelligence. And what they found was not only could the AI do it faster, but they were detecting cancers where they went back and looked at a rate of 20% more than the humans, the two readers. Um, what are the implications of findings like this? And are there some specialties that are going to be, you as a physician, you see, going to be more easily impacted by this?
Sure, you bring up a great example, and I like the radiology space because of its consistency, the standards, the regulatory oversights, the consistency in manufacturing equipment, and the consistency in training radiologists to read, say, mammograms. That's very, very helpful and fortunate for all of us, people that need to get imaging studies and have them read. It's a dream come true for the folks that work in machine learning because you have consistency in being able to train the machine. So the good news is that all the radiologists that I know, I'm not aware of any that are 100% against the use of AI in their domain. All of them are very supportive of using advanced technologies that will help them do their job better and help their patients. I don't know one radiologist that said I'll quit if there's ever AI in my space, because they've all taken advantage of better MRIs, better CAT scans, better software, right? They live in that world. I think that the challenge is they need to be very, very well involved in when AI is going to be introduced into their realm of interpreting radiology data and expressing opinions and actually reading and giving impressions. And that's where the battle space is, I think, of when do they ever get replaced to read mammograms? What's the workflow going to be? Are mammograms from around the world going up to a server that has the best ratio of success in reading accurately, and then the radiologist confirms or says mistake, or I disagree or I agree, right? How are we going to create this workflow? And so long as the workflow makes business and clinical sense, technical sense, it'll be implemented. It won't be
Right.
implemented when you don't have all the stakeholders at the table, and that's really the challenge.
Right. So, when you think about it, staying with this example, if you're detecting at a rate of 20% above humans,
Yeah.
risk is a funny thing, and we're going to continue to talk about this. There's a risk to not having that technology, that 20%,
Oh, yeah.
right?
Yeah.
And
So therein lies the double-edged sword, right? Is when you don't use something that's beyond contestation that it's accurate, and you choose not to use it, and then then there's an event. I'll just give you a little quick story. When I was a chief medical officer at a hospital here in New Jersey, I took all the general surgeons off the ability of performing pancreatic surgery. And they all came and screamed at me and said, "What are you doing?" And I said, "By the way, 3 miles away are 7 hospital systems, Memorial, Columbia, NYU, Sinai, that have specialists doing pancreatic cancer surgery 3 miles away. And none of you have done pancreatic surgery in the past 9 months. So the standard of care is so high 3 miles away. How can you possibly want to do a procedure that you haven't done in a year?" Right. But that was black and white. That was kind of easy to defend my position. But you could see
right,
where it winds up going, right?
You can, and staying with that, the law is still developing in terms of malpractice and artificial intelligence, and we can talk more about that later. But I could almost see it, and I don't do malpractice, so for all the providers out there, don't call me. But I could see on deposition saying, Dr. Smith, you didn't detect this mammogram as cancerous, correct? Now you see that it was. I do. Did you use artificial intelligence? Well, not on this particular image. Are you familiar with a study that says that 20% you
Yeah,
could see where it goes, and then it's almost the doctor. Doctors are in a very difficult position because they have to defend not using it, and then maybe the artificial intelligence, like any other intelligence, says, I think this is cancer. It ends up not being cancer.
right. So that's the false positive, right? So there's the danger is you miss the cancer. That's bad. There's also problems with thinking there's a cancer, but there's not. But generally people don't die from that. So there's you've got to hedge against where will you accept some risk. And in my experience with physicians that are being presented with AI solutions, algorithms, etc. They're so long as they're not coming out of some untested environment and being thrust upon them by aggressive sales folks. Try my product. We've got some good studies we did over here, we did over there. I think that's where people get nervous and concerned is they can't really ascertain the pedigree of the product to make sure that in fact it's as advertised. And that's part of the challenge, right? Is how did you train your machine? And who's standing behind the validity of that training set and making sure the program is as advertised 9 months from now.
Right. It's kind of like credentialing physicians. You got to credential in products. Is that
Yes.
something, well, one, is that something you do when you're asked by a provider, organization provider, what about this product? And if you do that, how do you do that? Like, what do you go back and look at?
So software, because we're software guys, the any software platform, forget AI, just an application that's going to do something with some piece of data or a large data set. You just go back to fundamentals. How am I accessing information? What's the security around it? How do I validate that the answer coming out of this platform is validated? How do I check every 6 months to make sure that it's as advertised? These are tried and true processes that software architects and other folks have been using, and it shouldn't be abandoned because there's a mad dash to maybe use something very interesting. It's the fundamentals remain the same. Really good doctors have great judgment. They may not have to be the most proficient from the best schools in the world, but they have good judgment
Yeah.
and they approach each patient the same way. They don't take shortcuts. And so long as you maintain that kind of standard, you can play safely with the AI ecosystem.
But not all AI is created equal, right? There are
No,
some, right,
no.
right. And we're seeing it in our part of our firm that reviews technology agreements. The AI companies are all trying to say, the provider, it's all on you. We're just a resource. You got to make the final judgment.
Sure.
I think that that's too simplistic. We're battling against that on
Yeah.
behalf of providers, but it's going to be a very interesting as this plays itself out. But I understand what you're saying about radiology being a perfect environment for this, right?
Yeah.
Are there other specialties that you see being impacted? And no one has a
Sure.
crystal ball, but you seeing about artificial intelligence?
Yeah, absolutely. There's, you know, the more well versed you are in the ecosystem, obviously, the more you can apply it to all the subsets of healthcare. But let's think about what's unique about radiology is that it's, there's this you're capturing images and you're capturing video, right? So, and then let's think about dermatology or pathology. Pathology is great. We're looking at slides. The slides have been prepared in a standardized format, right? When you have surgery, and they send the specimen down to the laboratory. The pathologists slice it up. They make slides. They look at it with good microscopes. That's a standard environment. So the machine does very well in pathology. The machine does well in images. dermatology is domain full of images, right? Images of of a rash on your skin, what have you. Surgery too is really, really very interesting because again, we're as surgeons, we live in a world of video. Now, what's really interesting is in surgery is that we're starting to finally adopt things like multispectral imaging, looking at your gallbladder from the inside with, say, ultraviolet or infrared, or for an 8K video, massive, massive data sets that your eye cannot see what the machine has captured. Therefore, if you want to play in that space, you're going to have to work in a machine vision environment. So it trickles all the way down, even into mental health, with the assessment of patients by their voice and or facial gestures and their prose. It's really wonderful that we're getting to be able to flex our muscles a little bit and play in this space, but not play as in play, but be able to bring to bear the good that we can extract from it and put to the side unnecessary risk.
Yeah, that's fascinating. And our audience has a number of GI centers that are participating. You see among different GIs, you see fluctuating abilities to detect cancer.
Sure.
And I wonder if at the end of the scope, you couldn't have an artificial intelligence type thing to the same way it's helping radiology, to help the endoscopist.
Yeah, so there's where I'm working on part of why I'm so excited at being at the Department of Electrical and Computer Engineering at University of New Mexico is, I don't know if you went and saw Oppenheimer yet, but probably a lot of people in your audience has. And, Los Alamos Labs and Sandia Labs and all these cool labs are in New Mexico. And there's some very interesting technology that we have access to and using that will trickle out. But what's really interesting for the GI folks, when you're doing endoscopies or you're doing, your procedures, just to give you a very scary number, if you shoot 1 hour of 8K video on your endoscope or in your laparoscope, that's not compressed, meaning it hasn't been crunched down, it's 72 terabytes of data. Now, 72 terabytes of data is a lot of data. It's not going to fit on your laptop. You probably don't have a hard drive that'll deal with that. And that could be just 1 hour of video that we need to do some complex AI with. That information can't be moved to the cloud because it's cost prohibitive and just file sizes are massive. So now there's a whole new generation, Andrew, of edge computing that's going to come down the pike. So you will have in the near future hospitals and imaging centers that will have affordable supercomputers on site, crunching through data in real time, because when you're doing an endoscopy, you may want to know something now, not wait, 3 days to get the answer back. So there's real-time analysis, and then there's this store and forward analysis. And that's the architecture I play in. That's how will we configure that? How will we do that? How do you bring value to the doctor, and at what cost? Obviously, the patient has to benefit foremost, but this is an economic, clinical, and technology dilemma, right? This is where we are now. This is the exciting part and the complex part.
And the scary part. Yeah, well, that's amazing. Okay, so I would love to stay in clinical operations for the remaining of time, but we're going to move on to administrative efficiencies, right?
Sure.
So we've got a lot of non-physicians, for example, on the symposium, running busy outpatient centers. How can AI, can you give some examples of how AI
Sure.
could help with administrative efficiencies?
Super easy. Let's think about the call center. Does every one of your clinics have a call center? Somebody answers the phone.
Sure.
Whether it's a person, two people, they outsource it. There's inbound calls coming in. Let me ask your folks. How many outbound calls go out from the calls from your clinics to patients to say, remind them tomorrow that they have an appointment? Remind them that they have to do their bowel prep for Friday because they're having a colonoscopy, or they didn't pick up their medications because there wasn't a ping back to the EMR that they missed their medication. They didn't pick it up at Walgreens yet. All of these administrative things that require what we call touch points. I'm going to call Andrew, make sure he shows up tomorrow at 10. Oh, I'll call Andrew that the 10 o'clock was canceled. It's now 11. Is that okay? Or do you want it next week? Right. So scheduling, bidirectional, let's call logistics, is primed for AI. conversational computing the side of the equation. And that's something that's not tech. It's not, you don't have to go to Harvard to be able to help people do scheduling, right? Humans are very, very smart. Do you want humans to make calls to say, Andrew, come in tomorrow at 11 o'clock instead of 10? Or do you want the human to work on a problem that you have, maybe with your bill or some other thing, and let the human mind solve a problem? So what we call this is a hybrid human machine workforce. When do we let the machines do the easy things that are repetitive? And when do we want the humans to do the things that are more complex? And how do you blend that? All that administrative stuff lives in that world.
So stop right there. And now let's go 5 years from now. Okay.
Sure.
So they're calling me. Why did you pick up your medication? I'm picking it up in an hour. That's easy. Machine knows what to do with it. But let's say I said, well, I did take it and I felt super nauseous. I don't know if I should keep taking it. 5 years from now, what can the machine talking to me, the artificial intelligence talking to me, what could it do with that? Or I say, listen, I have a question. Will I be able to go back to work in 3 days after you take out this or that? Can it do that?
Yeah, I mean, that's doable now.
Oh, is that right?
So yeah, that's doable now. Now, what's not doable now is the fact that I can't get all the information I need from you and from the systems of record that would help prevent you from getting nauseous in the first place. So, for example, all your medications, say I'm your doctor, your medications are in my EMR. I'm at the mercy of the EMR to rip through all those medications to calculate side effect profiles. I can't do that in my mind. I don't have humans don't do that, right? We need machines to go through. I have patients that are on 12 different medications. It's really hard to figure out which ones will cause side effects when, based on what you're eating or not eating. All that stuff is really complicated. So part of the beauty of all these things are, if I know what you're eating, I know how much you weigh, I know the medications you take, I know your blood pressure, I have a smart Samsung refrigerator that knows what the hell's in your refrigerator, I know your ShopRite account of what you've been buying, and I can walk through that and make some sense of it. I can start to help you before you run into this problem, and preventatively deal with some of the things that people get because they don't have the ability to be, let's call it early warning, or how to mitigate something in its infancy before it matures and festers. And that's a function of getting access to the data and being able to play with it. That's not a 5 year out construct. It may take 5 years to actually connect all the dots, but the machines are capable of doing that now.
So when, you hear about this all the time, and maybe for you personally, as an expert in this field, you don't have that fear, but I hear people worried about losing the human touch. Like, I know sometimes I'll just be hitting zero because I don't want to talk to that annoying robot, right?
Yeah.
And when do we cross the line over? Is there a line to cross over? Does it not matter?
Yeah, I mean, I hang up on those things all the time, and I'll tell you why. I don't hang up on them because I don't like talking to machines. I hang up on them because the companies that have implemented that avatar and that program didn't do a good job. I mean, this is the challenge. If you're going to present an avatar to a customer that's never worked with an avatar before, you gradually break them into the experience. And that's a user experience, user interface skill set that some places do really well and some places do really bad. So that's, again, the art. Medicine is an art and a science, right? We both know that. The best physicians are the ones that also can do that great human touch, right? They hold your hand, they talk to you, they look in your eye, they're not sidetracked. Same thing with machines. The implementing of a machine, say an avatar, to converse with you on a phone in a call center, there's an art to implementing it. And that's overlooked because people are in a rush and they want to put out some fires quickly. And once you poison your customer with a bad experience, you know how hard it is to get them back, right?
Right.
So
yeah.
That's part of the challenge, is implementing this stuff correctly.
And what you've made me realize in the conversations we've had over the last couple of months, Dr. Grasso, is how those verbal learning tools have changed. I think you were telling me that there's an anchor woman in, I think it's India, who
Yeah.
is an avatar. I couldn't tell the difference when you sent it to me.
Yeah, she's synthetic, and she's been trained, over a long period of time, and she communicates the weather report. Now she has a certain look and feel. She speaks in a, pleasant manner. I'm sure they had lots of focus groups, right? To fine tune her appearance, her cadence, her gesturing, all that stuff is all refinable. It's all customizable. And that's where you now, yeah, there's a big upfront cost to do that, but it yields dividends down the road, right? Because once you learned how to do that as an organization, you can spin up others. And that's to me, a well worth investment.
Yeah, fascinating. So we're gonna ask you one more question about administrative um, applications. Then we'll move to risk prevention. To the physicians on, and also the risk managers who have to chase physicians, medical record keeping is the bane of their existence,
Sure.
as is the billing systems that flow out from those. Can you just briefly give some examples of where AI might help both in medical record systems and billing?
Yeah, medical billing, I'm lucky. I'm a kind of billing, person. I like medical billing. I learned a long time ago that the better you understand medical billing, the better off the experiences for the practice, right? So medical billing is kind of straightforward from a provider perspective. If you're a general surgeon in a healthcare system, or a GI, gastroenterologist, whatever you are, aren't there a limited number of procedures you do? There's hundreds of CPT codes, that probably thousands, but there's only a certain small subset that's used by the practice, by the physicians. And the diagnosis codes that physicians use, if you're a general surgeon, there's a smattering of codes that'll be used, ICD-10 codes. Let's talk about that a little bit too, but there's diagnosis codes that are used. Now, if you're not using any semblance of analytics, if you're just doing straightforward medical billing, the doctor says, I perform the following procedure, and here are the three ICD-10 codes based on my diagnoses. And then the billing folks take that and they create claim forms, and it goes out, right? And you either get paid or you don't get paid, and there's a revenue cycle attached to that. Now, doing parsing, when you're doing what's called natural language processing and parsing, when you're looking at that data, when you're analyzing what Dr. Jones does versus Dr. Michael, they're both GI doctors in the same zip code, in the same practice. How different should their coding be? How different should their diagnoses be? How accurate and specific are they when they talk about their ICD-10 subclassifications? That's when you begin to see the subtle variations between things. Now you don't need AI to do that. That's analytics at that point. But as you mature that analysis of that information, you start to then have the opportunity to weave in, some AI into that to make more sense of it for your practice, to do more training up front, to know when you should train someone, to know when things are too repetitive. All that stuff comes out of that milieu. And it starts with, really starts with analytics before you jump into AI. And unfortunately, a lot of places don't even do really mature data analytics, because there's an expense, right, to doing data analytics.
Right.
But
Right. So, and that leads to the next thing, risk prevention. You mentioned before that it can pick up, I'm dictating, I'm a physician, it can pick up some things. How might AI hearing my voice be able to detect potential future risk problems?
well, it's interesting you bring that up. I did a project a long time ago on analyzing surgical dictations, and looked at the audio files from an audio perspective. Now, it was early, but we know that depending on an emotional state, humans change their pattern of speech. When people are nervous, that aren't trained on not to speak quickly, they may stutter. They change the way they construct their sentences. They speak quickly. They clip off the ends of words. They do different things. So analyzing, let's call it medical speech, right, from a perspective of just the audio is interesting, and it allows you to create patterns that's unique to the individual. And those patterns can be indicative of a problem, right? There's something happened in the operating room and you're dictating your note and it's not good, or or something went unexpectedly well or surprising. You went in to operate on something that in fact isn't there, and the radiology report said it was there, but it's not there. So now there's apprehension, or there's anxiety, and there's all these emotional states that are tied to patterns of speech. Now, I don't think places are doing that yet, but that's all within the realm of what we can do analyzing audio.
Wow.
Um,
Well,
and that's
that's amazingly scary, but interesting. Scary is the wrong word. It's promising, is what I would say.
well. Let's look at a good. Let's bring up a good example of why that's helpful. Suppose we're analyzing patients and we're helping them. They've got bipolar, or they have mild depression, whatever they have, and we can do telemedicine with them, and we're analyzing their speech patterns, and we're finding that people that are started on a drug for depression within the first 30 days, their pattern changes and they move towards a more calm form of speech. And over those 30 days, there's a crescendo and decrescendo and normalcy. We can take that data and help a new patient predict how they should do on this drug over those 30 days because of what we learned from our existing patients. So in that instance, that audio was helpful in helping guide a therapeutic treatment plan for a new patient, right? So it works both ways. It could be, it can work against you, or it can be helpful. And that's, again, we're back to the art and the stewardship of using this stuff, ethically, properly.
That's amazing. And you could also extend that, I guess, if you're talking to the patient who's been on the drug for 30 days and there's no change in their speech pattern, it might suggest that the medicine's not working.
Or they're not taking it, and unless you know that you didn't get the ping from the pharmacy that they picked up the medicine, then so when you talked about the 5-year thing, somebody says, I take the medicine every day and it's not helpful. Well, I just learned that you didn't even pick up the medicine yet. So now we're you didn't pick it up, or you picked it up and didn't take it. I didn't see you swallow it yet. I mean, these are all these are the challenges, right? And we all face.
It's amazing. So, Vince, I could talk to you forever about this. 2 more questions because our time is
Okay.
an end. First one, our compliance folks who deal with audits from Medicare, Medicaid, and every commercial payer, they're being like flooded, and they tell me that the sophistications of the audits are going up.
Right.
I guess my first question, it's a 2-part question. One, and I haven't asked you this before, is that because the auditing tools are using AI and they're getting more sophisticated? And is there something that providers can use prophylactically or in defense to help them?
So the let's just say large company versus small company. Large companies have resources that small companies don't.
Right.
Insurance companies have access to very smart folks in math, statisticians, data analytics people, all sorts of people that are looking at the vast data they have access to. They have a profound advantage in understanding what they're being fed and looking at it 9 different ways to Sunday, right? Imagine I put a team together of 30 of the people that I know to analyze medical documentation, right? So they are there. Now, what's happening is medical documentation is very easy to analyze from a perspective of things that should be different, things that are not as they should be, et cetera, et cetera. And that's not hard to do. The challenge for the medical practices is that if they're not even doing what I would call simplistic analytics, they're not doing complex analytics, and they're surely not doing anything in AI. So they start with a disadvantage of being able to analyze their data the way that the insurance company can. They can't even analyze their own data sets as well. And that's a challenge. And part of the challenge with things like generative AI and cutting and pasting from your EMR, cutting and pasting narratives, cutting and pasting things between your progress notes. The machines know that in an instant that it's a derivative cut and paste from something before. So those are things that are very easy to defend against with good regulatory oversight and providing guidance to these practices of what you should never be doing now moving forward in your medical documentation. And the payers are not interested in good doctors that are trying to do their best. They're looking for patterns of behavior that are not up to what they would like to see.
Right.
And they go after other people, right? So they shift their focus away.
Yeah.
You don't want to be caught in the radar. You don't want to be in the database of a problematic practice because of your record keeping, because once you're in that, it's hard to get out, right? And that's part of the challenge. It's not rocket science, but there's ways that they can be helped.
Yeah, and more training to the individual doctors. Okay, so last question. I'm a provider. I now hopefully have a sense of the promise and challenge of AI and using it and not using it. Besides calling you, what's the next step a provider should do at this point? As a provider of a large outpatient center.
So the provider, I know a lot of providers that have some interesting credentials. They were trained in physical sciences. Maybe they were physics majors in college, math majors. They're not all biology majors in college, right? Those people have considerable insights and abilities to help what I would call their management team go through how to explore and look at, let's just call them innovative technologies, whether it's AR or not. It's up to, I think, the C-suite to be able to have folks within that C-suite that can answer a hard question that's given by a provider. And if they don't have the answer to a legitimate hard question, they need to get an answer, right? It's not, well, I can't answer it, therefore it's not important. It's let's figure out how to get answers to these questions and have the physicians, I think, have a seat at the table with, being able to explore how we're going to change our technology stack moving forward, which is not a nice to have, it's a must have.
Right. And I think that's my takeaway is doctors are busy and running around, but they need to stop now because they may find that the future overtakes them, right? And now they're behind. So you got to get in, you got to use their brains and their know-how to really focus on this problem. So
I agree.
So Dr. Grasso, thank you so much for joining this 10th annual symposium, and we're going to have you back because you're fascinating. So thank you.
My pleasure, and thanks so much. Looking forward to chatting with you again. Take care.